Good morning, good afternoon, and good evening, everyone. Thank you for joining us for our March 2023 Global One Health Initiative webinar, supported by the NIH Fogarty International Center. Our topic for today is community-based participatory research to achieve health equity, and we will be hearing from Dr. Mahu Brunet, an associate professor in the School of Health and Rehabilitation Sciences and affiliated faculty in the Department of Integrated Systems Engineering here at Ohio State. You can see in the background, we have a brief few slides about the Global One Health Initiative. And now I'm pleased to introduce our speaker formally. Dr. Mahu Brunet, as I mentioned, is Associate Professor in the School of Health and Rehabilitation Sciences at Ohio State's College of Medicine. She also co-chairs Media and Communication in the Women in Medicine and Science, or WIMS initiative in the College of Medicine. She has spent 20 years in global public health research. And Dr. Brunet, I know that in your presentation, you talk a little bit more about your background. So at this point, if you want to go ahead and start sharing, that would be great. And I would just let everyone know, as I'm Christine O'Malley, I'll be the moderator today, and everyone should feel free to be submitting your questions using the Q&A function in Zoom, and we can get to your questions at the end after Dr. Brunet's presentation, but please feel free to submit your questions as we go. So at this point, Dr. Brunet, I will turn it over to you.
Wonderful. Good morning. Can you hear me well?
Yes, you're great.
Yes, great. I'm just trying to set up this. Excellent. So I'm sharing my screen. So I'm glad to, if there's any pressing questions before the end that you can manage, right? What's coming through the chat, I'm happy to do so. But good morning, everybody, where you are, wherever you are. And I'm Mahu Brunet, Maria Julia Brunet. I was born and raised in the Global South. I'm a global health scholar. My background is in industrial and systems engineering applied to public health, population health, and global health. And today I'm going to be talking about what are the challenges, because we need to be honest in terms of what really is to be conducting community-based participatory research. I'm a community center researcher. That means all my work is exclusively with community stakeholders, bringing them to the table and designing solutions. So just, I would like for everybody to just look at the image and what do you see? And just reflect. I know if we will have in a different setting in person, we'll be discussing but we're in a remote mode. But just think about, what do you see? Let's take a minute or so. And just quickly to explain to you in terms of where I'm coming from, I was born and raised in Peru, in Lima, Peru, a city of 15 million people, crowded, polluted. And I was born in a resource-poor area. You know, if you can imagine a crowded city, not just yet a mega city, but Lima is the central capital of Peru. And as you can imagine, everything is concentrated. It's centralized in terms of jobs, hospitals, and pollution, and a lot of the health problems. I just might say that my country, unfortunately, has a high burden of tuberculosis, where in Lima, which is a tiny portion, you see that red dot of the whole map of the country, concentrates 80% of all the cases of tuberculosis in the entire country. But anyways, my journey started where I was born and raised, and then I came through the United States for grad school and the University of Wisconsin Madison. And then from there, I spent almost 15 years in public health at University of Massachusetts, Lowell. And for the past 3 years, I've been back to the mighty Midwest at Ohio State University. So my background again is in industrial and systems engineering applied to tackle and to try to strengthen health systems to look for solutions for communities. So I'm a health systems engineer, a global public health researcher, and a social justice scholar. So in the global South, I work with resource constrained, marginalized communities to tackle big public health problems such as tuberculosis, maternal mortality, and maternal health. But here in the United States, I work with a large US Latino working population. So my modus operandi is really CBPR, and it's community-based participatory research. It has other names such as community engaged research, community center research, and I think there are a couple of other new terms recently published, but it's in my work as a human factors engineer, because that's my training, I integrate different models such as the social technical systems, and then the goal is to really strengthen health systems. So really what CBPR is, it's an approach in public health, in population health, to really work to address health equity. Because when you think about CBPR, it's really working hand in hand with community stakeholders, sharing decision making, and that is challenging for us academics. We occupy a privileged seat, right? And we have responsibilities to look for funding and try to tackle problems. But to be honest, CBPR, it's a very lengthy process in terms of identifying those key stakeholders, and most importantly is building trust, and then working together, and then really becoming true partners in the research. So what I'm going to do now is share with you some few slides that synthesize the principles of this approach. Now, the beauty of CBPR is that you have to adapt, right? As everything, in order to survive, we need to adapt. So for CBPR, we adapt those principles to the whole, I would say, socioeconomic context of what population you're dealing with. So this is a picture that I took actually in one of my field work trips to Lima, and this is in the outskirts of Lima, and that's a very typical setting in terms of, and this is kind of urban, right? But this is how the majority of people live in these areas, concentrated areas, where the phenomena that drives this is, number one, is poverty, and obviously the rural to urban migration. So let's get started. Perhaps the key principle of CBPR is that we recognize community as a unit of identity. And what does that mean? Community is defined not just based on the geographical area or a particular location, but it's really a group that shares values, cultural values, and some identities. In this example, I'm working with a large community in Lawrence, Massachusetts. These are residential construction workers or day laborers. So they don't have a formal employment setting, but we're working with them through promotoras. And in this principle, the community is defined as Latinos day laborers. And it just happened that they are all concentrated in Lawrence, Massachusetts, where 70% of the city is a Latino population. So that's my first principle. The second very important principle, and again, these principles are not ranked. These are all principles that in some ways, when you're implementing a CBPR project, sometimes it's just it's very fluid where your priorities, where are you focusing more, depending again on the scope of the project and the population, and obviously the specific health issue. So the second principle talks about in this strengths and resources within the community. And it's number one is really identifying what are those assets from the community. And as a researcher can strategically be thinking about how do I bring those assets? How do I contribute to strengthen the capacity building to be able to launch, to design, to launch, to implement, to evaluate, and sustain a project that is going to be the community project. So in this here, we're working with a group of nurses and nurse assistants in Lima from Partners in Health Peru, the sister organization. And we're just trying to do some community assessment and first identify what are the issues with tuberculosis diagnosis. That was a study a few years ago. The next principle says that CBPR facilitates collaborative, equitable partnership. And that is key because, and it's key, it's important, but it's perhaps very challenging. Again, the equitable aspect of that partnership is that we have to remind ourselves constantly of our roles and responsibilities, for the researcher, for the community partner, for the local government, whoever is our broad, our members in this partnership. So here we are in a community advisory board meeting discussing issues of tuberculosis diagnosis in Lima, Peru, and we're working with university representatives, health task force, the Ministry of Health representatives, the mayor's office, very important, and even advocate groups, TB survivor groups. CBPR promotes co-learning and capacity building. I need to tell you that I was very fortunate to go to grad school, get a PhD, but my learning has been in the field. My learning has been through CBPR, really learning the issues, really learning the complexities. And when I talk about TB diagnosis, and I'm always trying to be loud in terms of saying it's all about strong political will. And people say this, what is the connection? Because you really learn in terms of, from this public health perspective, to understand the issues and map the realities of what really needs to happen to tackle a problem, a population health problem issue that is so complex as tuberculosis. So all that learning comes from, we won't learn that from a textbook or from getting, it's really, that's what I'm always very grateful and have to recognize the value of conducting CBPR, community-based participatory research, because it's this capacity building is two-way. Is the community and representatives, stakeholders, organizations, and then academia, the researcher. And the same thing with capacity building. We may share with them, and we could train in research methods. We offer training in CPR, in community photo boys, in TB diagnosis, in community health workers. But we learn about the realities that are very hard sometimes to really, we cannot learn them from other sources because we're dealing with complex issues that are so prevalent in marginalized communities, voiceless communities. So if we don't work with them to tackle solutions, there is no other way that we can address those solutions. This is another project that I conducted back in 2012 with a large industrial, in a large industrial setting, 3,500 workers, industrial workers. And the simple question always started with convincing management that occupational health and safety is very important. The health and the well-being of the workers is very important. And it all began with multiple sessions with different groups of workers with a simple question of how work impacts your health. And it was phenomenal. And this project was only successful because management really was willing to, again, share that, kind of come to the table and listen and understand that through a small steps, simple practical solutions, we can achieve a lot in terms of the worker morale, the worker productivity, obviously in this case. CBPR places a strong emphasis, I would say, on public health problems. So it's a pre-step to really try to achieve health equity and this socio-ecological approach, as I was telling you, in terms of the multiple layers and the complexities of an issue. So it's not really the individual level or the organizational level, in this case, a healthcare setting, but it's more so that really CBPR, because you're engaging multiple stakeholders, you're really trying to move the needle and address the problems with systemic solutions. So I'll continue to share with you one project that started around 2016, and it was supposed to finish around 2020, 2021, but COVID really delayed that. But I'm happy to share with you my project that it really tried to use technology. So the question is, the process of diagnosis tuberculosis is lengthy, it's not efficient. And of course, we know the issue in a city of Lima, 15 million people, with a high burden of TB. We don't have sufficient resources in terms of doctors, pulmonologists, and obviously, though all these healthcare centers in the city lack resources for proper x-rays and even some of in the labs. I mean, so it's a very complex situation. And we know all about TB as a leading infectious disease, and the most important aspect is that it's curable and preventable. And I need to tell you, right? I was born and raised. I lived, let's say, half of my life by now, half of my life I live in Lima, Peru, and the other half here in the US. And I really feel ashamed that even though I spent all these years and studying engineering and really thinking, what are the issues, I was so ignorant about the burden of tuberculosis. Because it really doesn't, it's not in the headlines. It's not an issue that people talk. And that is something that is changing now, and that's very good, but and I assume in research pool settings that is a problem, or you take that by granted that who's infected with TB. So it's a big stigma also. And as we all know, TB is a disease of the poor, but in the global south, it's not a disease of the past, unfortunately. So our aims in this study were how do we use technology to really speed up the process of diagnosis tuberculosis. We are a team that included computer scientists, social workers, very important, nursing, health systems engineering, public health, and obviously in school medicine, pulmonologists. So we were trying to, through many, many sessions here, both in the US and in Lima, Peru, with the local, all these professionals in the local settings, to really think out loud, what do we do about it? How do we go about it? And it turned out that we could effectively use technology, effectively, I will tell you later. We thought that we can use technology as to really speed up the process through computer CAD, computer automated diagnosis tool that all these multiple clinics could have access to, with a tool for the nurses to assist them in a preliminary screening, I want to say, of abnormalities in the lung that could be suspicious for tuberculosis. So it was a really learning curve, right? This project is 5-6 years on the making. We're still talking about it, and we're still thinking where we're learning and what are the next steps. So let's take a minute in looking at this model. Hello? Can you hear me? I
Yes,
couldn't hear
yes,
them.
we can hear you.
Okay, sorry. Okay. I don't see the bottoms because I'm sharing. Can you hear me now?
Yep, can still hear you.
Okay. So in our approach, what we had to really look and understand was the healthcare establishment, the TB clinics, and understand that as a work system, and look at these different layers in terms of technology and tools, physical and mental tasks, physical, social environment, and the organizational factors. Very important because they all interact and they all will impact if we will have, because it's not an easy as say, well, let's just bring an app, right? And this app is going to help us, reduce that time between a patient shows up at the TB clinic and is diagnosed, and most importantly, begin the complex process also of the whole begins the treatment. So what we in this social technical systems model, where we have these 4 elements that are in gray here: technology and tools, physical, mental, physical, social environment, organizational factors. We needed to understand what specifically we're focusing on, and it was TB screening and diagnosis, assisted by a computer-based system. And our outcomes were obviously to reduce the time to begin treatment for patients, but also to really look at issues of workload for the nurses and to understand what really in the relationship nurse-physician and the relationship healthcare workers and patients, and all the challenges for the TB screening diagnostic. So in other words, when we have this systems approach, it's not just looking at one element, but really looking at the multiple elements. And we call this a work system, which in this case becomes the clinic. So we did, sorry, this graphic, it could be like, oh, wow, what are they doing? So that's when I say the other importance of CBPR is that you have to use a lot of our qualitative and social science tools. Very important in this assessment, because you need to understand, going back to how the system works. And for us to understand how the system works, we needed to conduct several lengthy, process of digging into those key stakeholders, physicians, nurses, psychologists, social workers, radiologists, to understand what are the issues. So we did a large, needs assessment, or community needs assessment, as I could call this. And I apologize, it's all, now I realize I put the wrong one in Spanish, but anyway, so we have some observational studies where we have our trained Peruvian grad assistant going into the following the nurses and the nurse assistants in the TB clinics from 7 a.m. to 3 p.m. or whatever were the different shifts, following for several weeks and doing a daily observation of their tasks and their interactions. We also conducted several interviews to both nurses and the whole set of participants in this needs assessment, and we also did focus groups to understand in 15 different TB clinics in 3 different districts in the city. So as a systems engineer, what we do is we map the processes to really understand. I mean, we use that term that I don't like it very much, but it's bottlenecks. So what are the bottlenecks, right? And how can we optimize the process? How can we stop redoing and not taking shortcuts, but really make the process more effective? And that's an analysis of what we do in conjunction with the community and our partners, local partners as well. And then with our computer scientists, we share all that information and then try to say how we're going to use technology. So the process of using machine learning will only be effective if we're really having a deep understanding of the system, how the system works, and how we're going to implement this. And then at the end, it can look like something as simple as an app in a phone, but the whole process, and I will share with you, it's complicated. It's rewarding though, right? So you see here some of the images of the local settings where our nurses are using the EREX, what we call EREX, this app. Now, what you see in the picture, right? You see, I think through that image, it could be kind of clear in terms of we're going to be taking a picture, uploading that in the system, and perhaps waiting a few seconds and get a preliminary score in terms of abnormalities first, and then suspicious for TB. And now this was this is the fall of 2018. And then, well, I spent a whole year in my sabbaticals in Lima, working in this multiple clinics. I mean, not working like them as a nurse, but really going on weekly visits and weekly rounds in terms of understanding confirming how the system works, what are the issues. And I need to tell you that it was 2018, and the nurses, with their creativity and their motivation and their commitment to their roles, we're already doing something similar to this. Something that long time before we arrived to discuss how do we speed up the process and do all these interviews and all this mapping, they were already thinking, and it was using WhatsApp. So they were already using WhatsApp. And the nurses, because they knew all this backlog, of cases and decisions only, being available once or twice a week. They will connect with the physician through the WhatsApp and really put pressure in terms of their observation of the conditions of the patient. So it was very interesting. So we try to not convince them, but really explain how this app will work and where were the benefits. And that was a very good learning experience. So my computer science colleagues really evolve and develop a predictive model. I think it was the fourth consecutive years, and I'm polishing this. Even creating the model, also we had the local partners contribute to that through the Ministry of Health, where they provide total almost, it was the exact number is 4,800 X-rays that were annotated already by pulmonologists. And we had all the various manifestations, lymphadenopathy, all the key 6 major manifestations of tuberculosis classified in all these images. So what they had to do is really learn, computer scientists, in terms of training the model in the database. And they created this annotated software first, which allow an expert, it's my colleague, Dr. John Bernardo at Boston University, who help us in all this lengthy process of annotating, drawing these polygons in all these multiple X-rays. And we had a team led by Dr. Bernardo. As you can see here, we have Dr. Bernardo. These are my computer scientist colleagues, and multiple sessions. So it was a very lengthy learning curve in the process. So if I may add here, I mean, very positive unintended consequence is that we end up having this repository of images, again, close to 4,800 images, where as our computer scientists have been through all the work and the process of classifying and through the annotation software identified the regions in the lung that will have these abnormalities. It was in one of those stakeholder meetings in Lima where they say, oh, wow, well, this was the previous step to use to create the app, right? And to have it available for the nurses. So they say, so what are you doing with all these images with this repository? Because our medical students and people engaged in TB work can really benefit from learning. So we end up in the summer of 2021, we had a course with 300, 400 medical students and nurses on the use of this repository and understanding how to interpret, read, identify the various manifestations for tuberculosis. So the question, as I say here, thinking out loud, right? In this small clinics, in this study that we did, is really how can we translate and scale up evidence-based mobile health and health interventions and policies in both urban and rural community settings. What we learned from the experience is that the app was not going to solve the problem. We can have the perfect app. We can have the best phone that we can bring there, but it wouldn't solve the problem, because basically we need to look at the system. We need to look at the relationship nurse, physician, the issues there. We need to look at the technical problems. In some of during my field work, we had time stamps of when the data was being submitted in terms of the x-rays images, and we had a pattern of, based on the nurse chiefs and stuff. And there was one particular clinic that I recall, suddenly the time increased significantly. And that's one of the things we were measuring. How do we cut that time and make this app effective in speeding up the process? And when I will go to visit and ask questions, it's not really blaming them or why are you taking so long to take pictures and submit the photos, but it was that the nurse had to walk 2 blocks. She had to have, from this clinic, she had to walk 2 blocks and raise her hand so she can have connectivity and upload the images to the system. And things like that we will not learn if we're not really working hand in hand with the community. The other issues that we also learned were in this intervention that physicians were reluctant to really, obviously not just the trust of the app, but it was more so that the information they were being communicated from the nurse. So the physicians and the nurse relationship needed some understanding, because it was always the physicians having not just the decision making, but the really more, I would say, autonomy on the job. But it was really the sharing process of that responsibility, perhaps I should say that is what it was complicated. So our project, we did the pilot in the 2018-2019 academic year, but it was, and when we were going to launch to the broader study, COVID hit, 3 years ago. So as you can imagine, all the healthcare workers, nurse technicians primarily, which are a total of perhaps 1,300 in Lima, those only focusing on TB, 1,300 nurses and nurse technicians were pretty much taken out and then thrown to COVID work. So as you know, we have redressed, we have COVID has really exacerbated our fight against tuberculosis, and it just became complex. So what we end up actually doing, and that's for another presentation, we end up doing a large community photo voice with TB patients and understand a broader issue of the social determinants of health. But we couldn't really implement the app as we wanted to in the 2020-2021 year because of COVID. So this is what we end up doing. We partner with the a large TB survivor group, and we end up doing a study with 176 patients. Started the study with 176 patients and finished with 130 current TB patients in the city of Lima through first training the community health workers in social research and tuberculosis, and everything was managed via Zoom. You can imagine, locally, and obviously I was here. But it was important because we start drafting this process of what are the solutions in terms of diagnosis, and we learn a lot from the process. We're almost completed in the process of publishing the results, but these co-creating solutions, again, are the process in itself calls for attention to not just folks in public health, but it's really a more systemic aspect of mayor's offices, Ministry of Health, local government, and the public. Very important. We need to raise awareness to the public, and that's what we're trying to do, working with health educators. And for us, the results of this journey of 5-6 years is going to be public education campaign, because I think it would raise the topic of tuberculosis. So as I was telling you, half of my life I lived there and I know nothing about the burden of TB. And it's 2023 and still that's the same phenomena. So in Lima, the majority of the people are very ignorant about the burden. And understanding the whole systemic process of how really, why is TB disease of the poor and the relationship of poverty and health equity, I think we will have at least contributed a little bit to move the needle towards the solution. So that is what we're trying to do now with the local, the medical school in Lima. And that's what I have. I'm happy to take all the questions you may have. Happy to
Thank you
discuss.
so much, Dr. Burnett. This was extremely interesting, and your experiences, you know, just so amazing at how you've improved people's lives through this work. A couple questions just to start off with.
Yep.
So you talked about, you know, community-based participatory research and how important it is to involve the local community early on. But is there a threshold for community involvement for something to be considered CBPR?
Oh, that's an awesome question. There's no number or metric that we can have, but I think it will depend in the scope of the problem, right? In the scope of the problem, the burden, the where you really who is really most affected and how are we engaging them? I think that's the core aspect. Is really not about the quantity, but in terms of that alignment of who's on the table, discussing what problems. You know, this problem matters to who and is affecting who. So, for example, here in Franklin County, I'm working with in a CBPR project with the Ohio History Connection. They have a community engagement office. So I reached out to them and I said, I you know, a couple of years ago, I'm new here. I'm trying to see what kind of work we can be doing together. And they're not public health, but I was referred to them as a community engaged, very active. So we said, all right, well, we kept talking for 2 years. And now we're working in a beautiful project with a parent strengthening parent support group with African American mothers who are really very empowered and they already have their agenda in really supporting each other in the community. Wayland Park, it's called. But the goal is really, so I come here with a research, right? Structural systemic racism. But obviously I'm not presenting the project to them, okay, we're going to talk about structural systemic racism. No, it's an old thing. They already heard the word racism, it's popular. But we start digging into that needs assessment, into the issues, your quality of life, your day-to-day life, your life experiences, your concerns about your children, what's happening at school, what's happening at work. So who's on the table? I have a group of 8 mothers, and then the community engaged coordinator at Ohio History Connection. And we do this in a safe place, not OSU, perhaps. And I don't want to say OSU is not safe. It's safe for the community where there is the trust. So building that trust, I'm taking advantage what Ohio History Connection was really hosting this parent support group for 13 years. So I come here and really, I have to, right, work hard and really through listening and through building, that's how you can, I don't want to say successful, but you can start trying to design this solution.
That's another really great example. And as you're talking about that one, and then the earlier one, when you mentioned, you know, how the physician nurse relationships, how, you know, you looked at that as a system, and, you know, the information sharing and the authority in those relationships, as well as the example you gave of the industrial workers, it really struck me that that some of the benefits from a community-based participatory research project extend past the life of the project. And I was wondering if you could talk about if you've seen that, once a specific project ends, if you've seen that these benefits live on in other ways.
Oh yeah, and when we talk about sustainability, and that's one aspect, someone needs to write about sustainability. And the sustainability is just not in that specific project with those specific project objectives, but really goes beyond that, right? So I think one of the key words that we ignore or we don't remember too much with CBPR is empowerment. So it's community empowerment. We empower and capacity building. So you learn from the experience and then you tackle another problem to the community, not to the researcher. So that's how I see that the CBPR brings that and extends past the project end date. For us academics, we depend on funding and we have our start and end date. But really it's through CBPR that we can see that, I don't want to say evolving, but it's really the community bringing their own creativity and motivation to tackle the issues, and that's how they continue and move on. Yeah.
Great, thank you. Dr. Cabreras, I see you brought yourself on camera. Did you want to jump into the fray? I've got a few more questions on my end, but I didn't want to monopolize the whole conversation. Feel free, I know that you have a wealth of experience in this area, so feel free to jump in.
I think he's mute.
I think you're on mute. Yeah, there you go.
After 3 years or more, we can't learn the mute button. Yes, so thank you so much, Kristen. Thank you, Dr. Brunette, for your presentation. Definitely have a quick question as well as comment. I think what you presented, regardless of the discipline within the health sciences or geography across the world, very much applies. In my background in veterinary medicine, and as someone who practiced in sub-Saharan Africa in Ethiopia a long time ago, when you engage community animal health workers in research participation from the communities, many things you spoke about very much applies. But my question, and I'm just wondering if you have seen what we used to see in Ethiopia, for example, in south part of Ethiopia, where you engage community members in this kind of activities, you empower them, like you said, which would be a wonderful thing, lots of positive impacts. But then what we saw, at least long time ago, and some people from Ethiopia can correct me if I'm wrong, the community starts viewing those people as if they are knowledgeable of even clinical practices, other things. Sometimes we see the consequences in the clinical area now, those community members not only being viewed as knowledgeable of veterinary medicine, but then they start practicing giving injection or things like that. Going beyond the intent of participatory research. Do you see that in the regions you work with or in the human medicine aspect? I'm just wondering, but look forward.
Yeah, that's a very good question. And we learned that through the last phase of the project in doing the community photo voice, where we're talking about nutrition, for example, right? Nutrition and food insecurity as one of the key aspects in the relationship for effective, successful treatment and for patients. And obviously, that's when I start, with what you just said, realizing that there were so many different perspectives and not were necessarily true, or right, what are your sources, why are you doing this, or the comments that I will start receiving from the participants in the Zoom. And I think that's why it's important in terms of how is the structure of your partnership and who can really lead in. So we will always go to the TB survivor group coordinator to really, we're thinking this. So it's important that we connect them with who they trust and who can be really telling them, not us, right? Not the university necessarily, but it's really when you realize that you need to quickly do a health literacy intervention or something that is really important in terms of what is really correct, scientifically or academically or medically correct. Yes. Yeah.
Thank you.
And Dr. Burnett, what do you see as the future of community-based participatory research? Do you see that expanding into other areas? What do you see as in the next few years, how this approach is going to evolve?
Well, I think the whole world is watching. We have awareness, we have advocates, we have a commitment to the youth. I think in training students, it's not just an approach, but I think even institutions, universities are responsible for this, right? You read all the missions of universities, and what do they say? We want to create impact. We want to train the future change agent. And then you try to align that to the research enterprise, and I just find that the change has to start from that. If we are responsible, we have this privilege, really is universities, not just an office, right? I mean, there's an office of community engagement and you get 2-3 awards a year. You don't solve problems if you really don't have to change from the inside. And I'm very, very vocal about this. I seek to disrupt academic systems to really understand that we need to work with communities. And it's not easy, it's challenging. Some days I say, ooh, right? I like everything in our lives, but it's really working with the community and that we're going to be able to address issues. And when you think about globally, because we're talking in global health, it's this whole process of how are we achieving the sustainable development goals? And there's no political strong will. Like, well, let's start working with the communities. Let's start really working with the communities. And I think, to me, that's the only way we're going to try to achieve some of these critical goals and also equity.
Thank you. We just had a question submitted. How can we, and I think maybe the person means we as researchers, how can we build community trust?
That's key. I think first we need to dig into, for a particular issue, health issue, we need to identify who in the community is really an advocate, an ally, and who's working on that. And then we have to reach out to them and then try to learn about the problems and really connect to the key people in the community, not just the affected person, but who is already doing something. Like, for example, when I arrived here, I know the opioids and fentanyl crisis is serious in our region. So I started learning not just, who is doing opioid research at OSU, but really what's happening in the city with Columbus Public Health, the coroner's office, the advocate groups, a lot of research, and try to set up meetings and talking and learn the problems. And from their perspectives, what do they see as solutions? So it has a lot to do with being strategic as researchers in terms of a particular problem and being flexible. Being flexible doesn't mean not being ethical. We need to follow all our procedures in place, but it's really being flexible and then bring that to the table. If you identify a community issue that is perhaps a little beyond your expertise, then you bring your colleagues and try to tackle, assemble a team, and from that point, yeah.
Yeah, it
move
seems
forward.
like
Yeah.
there's a balance, a really nice balance in what you're saying between that pragmatic, strategic approach and the flexibility and the empowerment. I love how that's all working together. Let's see, we have another question. Do you think we should always share our results with communities? How was your experience in your project?
Oh, yeah. There's no way we can, and that's perhaps a critical step in creating change and sustainability, and then really reaching who we should be reaching out. So in CBPR, you have two outputs, which is obviously this, you're funded, you're in academia, so you have your standard academic publications, peer review reports, etc. But you always have to think about the non-academic, non-traditional outputs. So graphic novels, cartoons, infographics, and that's what I've done over the past 15 years. And those images you've seen, we have partnered with cartoonists, with art designers, with health literacy experts. How do we convey this, what we're writing, in an academic paper, into a just single 3-panel comic strip, for example? And that's how we, and please, it's not giving to the community. It's really doing what we are supposed to be doing. So.
Thank you. Well, before I turn it over to Dr. Berrien to close this out, oh, wait, you know what? We did just get one more question. I'm going to ask that before I turn it over to Dr. Berrien. Our last question, though, for this session, how best can we bring the key values of fairness, respect, care, and honesty while working with communities? I think that's a great one to end on.
Oh, it's a great question. There is no answer. It's just an ongoing process of learning cultural humility, right? Cultural humility is very important. And cultural humility is not about race. It's not about who is the academic, who is white. I'm a brown person of color. It's really understanding our roles as citizens in addressing a problem, because the patient or the survivor of domestic violence or the substance use disorder affected person or community is not in a different position just because they are. So it's really understanding that and really working on a day-to-day basis. It's what we do. For example, one thing it's very important and it helps in transparency is we establish MOUs. So for example, and they take a long time. It's like as lengthy as doing an IRB, right? An MOU. We have clear roles and responsibilities in academic, in community recruitment, in communication, and then I have an MOU with OHC, Ohio History Connection, with the Parent Strengthening Group and OSU. So we have our roles and we discuss about the roles and then we sign the MOU. But it's not rigid. We might have an issue 3 weeks later, right? And then we have to really go back to that document that really is our contract, social contract for us. So.
Thank you. And we did just get one more question. And since we have a little bit more time, I just want to squeeze in everybody's questions. So paravets have been trained in the remotest part of Ethiopia from the communities to perform simple diagnoses and treatment. Do you have such experience in Peru in terms of human health?
What do you say? What
Paravets, and I'm not sure what that position is, Dr. Cabreras. I don't know if you can join on and tell us what paravets are in Ethiopia.
Are they students?
These are community members. Where in the remote parts of in sub-Saharan Africa, it's practiced in many other countries as well, not just Ethiopia, but the person asking the question is referring to Ethiopia. But these are community members. It's not really for participatory research purpose, but in remote areas where there is no doctors of veterinary medicine in those areas, or veterinary health assistants. Then community members are trained in a short-term purpose to be able to diagnose, some very common animal health problems. So those are referred as paravets. They are not veterinarians, they are not animal health assistants, they are community members, very shallowly trained. That's what I was referring earlier. It's very kind of dangerous when, anyway, you can answer it based on the question from your point of view.
So,
Yeah, in terms of for human health, all I can say is that particularly in the rural areas, and just in general, not just for TB, we have healers, right? And there is a lot of trust from communities, and the effectiveness has mixed opinions. So I don't have really sufficient expertise or life experiences to really make a critique about their effectiveness. But in terms of the trust, it is important. And I think particularly in the rural areas is challenging, but it's important, the work of trained people, medicals, nurses, to really pay attention and seek solutions to the issues of building that trust and building that trust in what they do.
for sure.
I
Thank
think
you.
the earlier point you raised is very critical. Joseph Nguta from Kenya asked that. So I think, definitely as you engage in research parts of participation, you want the community to be informed as frequently. That's a big incentive, is to inform them what you find out, right? So otherwise, you can't build the trust. They lose interest to participate. We've seen this in veterinary medicine side as well, including in Brazil. When we did research in this Federal University of Paraíba on a simple diagnostic method, PCR-based method to detect milk adulteration, milk between bovine milk and goat milk. It's a different from your area in Peru in human health, but this is milk adulteration for the sake of human health and wellness. But there is some economic incentive. Some farmers adulterate milk with milk, goat milk with bovine milk. So when we develop that taste together with Paraíba leaders, professors from there, we want to inform the community as they participate, and they want to know what you find out. So that is very critical part of building trust. But on the other hand, when you involve them, and especially unless it's really controlled engagement, if the community perceives them just like the paravets, then people see them, even sometimes refer them doctor, blah, blah. So they're referred as the doctors, all of a sudden, so if you imagine, if the community members start prescribing isoniazid or rifampin or rifapentine, blah, blah, then it could be dangerous, right? So there is an advantage and disadvantage of that.
Yeah, that's critical. And that, again, that culture of humility to really try to bring the truth, right? The evidence in a respectful way that is not really, it's really acknowledging the root cause, that why does those informal systems exist. And it's because those are really abandoned areas, really marginalized communities where, there is really access to healthcare and good healthcare. It's really minimal. So.
Great. Well, thank you, Dr. Brunette. Again, this has been really wonderful. I do want to give you just one opportunity if there's anything else you wanted to say or share with us on this topic before I turn it over to Dr. Berrien.
Well, for me, it's an honor to be in this venue, and not physically, obviously, but really, I really appreciate the work that you do, the Global Health Initiative. I'm very grateful that you give me this opportunity. And all I want to say is community-based research. It's really, it's a practice. So we can start very little. We don't need to be thinking about complex, large projects. We don't need to be thinking about the most leading killer disease like tuberculosis. We could be thinking about smaller steps and then we can just try to contribute to move the needle a little bit.
Thank you.
Thank you. I'm grateful.
Thank you so much. And now, Dr. Berrien, I'll turn it over to you to close
All
us
right.
out.
Thank you so much. Thank you as well from my side, Dr. Brunette. Really impactful work, really inspiring. I think all of us as researchers can incorporate elements of what you shared, regardless of what field we do. So thank you for that. And thank you for Christine for your skilled moderation as always. So just wanted to share an announcement with you all. If you don't know me, I'm Amanda Berry, and I'm the GOHi Director of Outreach and Engagement. So today I wanted to announce that this month's webinar is going to be the last of its kind in this current format. So this has been a live monthly webinar we've been doing for the last several years, as many of you know, and it's been an important part of our outreach and engagement mission that we feel very strongly about at GOHi. But our team is working on updating our outreach strategy to try to match the evolving needs of our diverse One Health community that we know we reach our collaborators, our attendees from all over the world. So we're excited to see what comes next and to share that with you when the time comes to do that. So please stay tuned. You can continue to receive news and updates from the GOHi team and our partners and collaborators on the work that we're doing through our monthly newsletter. So please make sure, if you aren't already, to be signed up for our newsletter to receive those updates. You can do that by visiting our website to stay engaged with the current work that we're doing and learn about our future outreach opportunities. So thank you all again for tuning in today. And for our previous attendees that have been with us these last few years, and we'll be in touch with what's next in the future.